So, as an overview of the talk today, I just want to let you know what we'll discuss is number one, the basics of heart valve anatomy and function of heart valves. We'll try and understand the ways that heart valves can degenerate, both all of a sudden or over time. I'll try and focus on two of the most common heart valve issues that occur in our population, review the symptoms that can occur when these heart valve issues are present, and finally provide an overview of the state-of-the-art treatments available at Capital Health System. One thing that's always nice to do is start out with 5 interesting facts about the heart. One thing to know is that each day, the average heart beats about 100,000 times. Each minute, your heart, which is a pretty amazing organ, pumps 1.5 gallons of blood through your body. Heart disease remains the number one cause of death for men and women in the United States. A normal heart is usually about the size of a half-dollar coin. And then finally, the largest heart ever recorded belonged to a gray beluga whale. The heart itself has a simple function. What it's supposed to do is take blood from the lungs and pump it out to the rest of your body. This oxygenated blood provides nutrients to all of your cells. It also takes blood back from your tissues after your tissues have taken out the oxygen, brings that blood up to your lungs where gas exchange can occur and the oxygen can get into the blood for eventual return back to your tissues. The heart has a few different parts of it that are very important to understand. At the top of the heart are two chambers called the atria. There's a right atria and there's a left atria. The atria themselves are smaller chambers, and their job is to receive and collect blood. The bottom chambers of the heart are called the ventricles, and those are the two lower chambers of the heart whose job it is to pump blood out of the heart either to the lungs or to the rest of the body. There is a separation between the right and left sides of the heart, and we call that the septum. The septum is a piece of muscle that divides the heart into the right side, which is the venous side returning blood to the lungs, and the arterial side, which is the left side, which collects blood from the lungs and sends it out to the rest of your body. Within the heart itself, there are 4 heart valves, and the names are what we see listed: the tricuspid valve, the pulmonary valve, the mitral valve, and the aortic valve. These valves are present to prevent backflow of blood from one chamber to another and to keep blood flowing in one direction. The tricuspid valve, which is encased here in blue, separates the right atrium from the right ventricle. That allows blood to come back from your upper and lower extremities, drain across it, and go into the right ventricle of the heart in preparation to go out to the lungs. The pulmonary valve, which is encased in the blue square, takes that deoxygenated blood and allows it to go through that valve out to the lungs and prevent anything from draining back into the right side of the body. The mitral valve is the valve that separates the left atrium from the left ventricle. The left atrium is what collects blood from the lungs, and it goes across the mitral valve into the left ventricle in preparation to go out to the rest of the body. And finally, the aortic valve is what separates the pumping chamber of the heart, or the left ventricle, from the aorta and all the blood vessels that go to our tissues. When you have heart valves, we like them to be healthy and normally function. At the top right, you can see what a healthy valve looks like. It's relatively soft, it's able to open and close when it needs to, and it protects the heart from having blood go in the wrong directions. Stenosis is when a valve has degenerated and the valve itself resists opening. This forces the heart to work harder in order to push blood from one chamber to the next. Normally, valvular stenosis or restriction occurs over many, many years and usually decades. So this is a chronic, long-lasting process that goes on for decades and decades before it's symptomatic or detected. Regurgitation, which is otherwise called incompetence or insufficiency, is when the diseased valve opens well, but when it closes, it allows blood to leak through it in the wrong direction. This kind of problem can occur over time, or it actually can be all of a sudden. When it happens, the heart works much harder because a portion of the work it is doing is going in the wrong direction. So if you look at this diagram and see the left ventricle, which I'm outlining with my pointer, if the mitral valve pictured here is leaky, then when the left ventricle squeezes, some blood will go in the correct direction, but some will go backwards. And when that happens over time, the heart works harder and harder and eventually develops failure. Of course, valves are not that simple. Valves can have both stenosis and regurgitation. So whenever you're evaluated by a physician or a medical team, we always look at whether there's one problem, two problems, or both. What I'd like to focus on today are two particular valve problems. All of the valves can develop stenosis or leakiness, as you can see here. But I'm going to focus on two problems that are really highlighted in medicine and for which there are a multitude of patients affected and also treatments that can help. One is called aortic valve stenosis, and that's when the aortic valve, which is right here, or in this diagram right here, that's the valve that separates the ventricle from the aorta. That becomes restricted and doesn't open well. And I'm also going to talk about a second problem called mitral regurgitation or leakiness, where the mitral valve that separates the pumping chamber becomes leaky. Aortic stenosis is a very, very common problem. Some estimates say that almost 17 million people above the age of 65 have aortic stenosis. It's prevalent in up to 7% of the population. It is more likely to affect men than women. At this point in time, 75 to 80% of people affected are men, and it is progressive in nature. It is a problem that affects you more often as you get older. Now, what can cause the aortic valve to become restricted or stenotic? The most common reason is what's called age-related calcific aortic stenosis. And that is when over time, just based on wear and tear, the valve becomes degenerated. And as it becomes degenerated, the valve will restrict opening and cause symptoms. There are also other reasons why the valve becomes restricted. One problem, which has had a little bit of a comeback, is people who have had rheumatic fever as a child, maybe as a teenager. Those patients get injury to multiple valves, and their valves may become stenotic over time and become symptomatic. Lastly, there are inherited or congenital abnormalities. valve problems you're born with. The most common one is called a bicuspid aortic valve, and that's when you're born instead of with three pieces of the valve to open and close, you're born with two. That valve can function for 40 to 60 years, but it tends to prematurely fail and become stenotic, and that's the third major category that we see. Here are some representations to show you what these valves look like. So here is a normal heart valve with three leaflets, 1, 2, and 3, and you can see how soft the leaflets are. Here is a valve at the bottom, which is very scarred. You can see little calcific nodules that are on it, and you can see that this valve itself is bulky. We call it bulky calcium, and it doesn't open well, and it doesn't close well. This is an image of a bicuspid valve, so you can see hopefully the two leaflets here. Here's one, and here's a second. And you can see the degeneration of the valve just like in the bottom right frame, and that bicuspid valve has prematurely failed. And here is a patient with rheumatic fever where it's not so bulky, but it's more inflammation and adhesions that cause the valve to prematurely fail. Now, it is very important to understand that aortic stenosis is something that is there really for a lifetime. Aortic stenosis over time can be quiescent, so people for decades and decades can have absolutely no symptoms. But once they get into their 60s or near their 70s, all of a sudden they'll feel the symptoms of aortic stenosis. And those symptoms can be many. The typical ones are chest pain, passing out, or shortness of breath. When a patient gets symptoms from aortic stenosis, the survival rate at 5 years is only 20%. So we truly encourage patients who are symptomatic to seek a physician's opinion to see if there's a valve problem that needs to be fixed. As I said, the signs and symptoms are fairly classic for aortic stenosis. They can be shortness of breath, what we call heart failure, chest pain, what we call angina, or passing out, which is what we call syncope. The doctor really needs to put a stethoscope on the patient. So the doctor can hear multiple different physical exam signs that can let them know that the aortic valve might be having a problem so they can order the appropriate test. There are lots of different ways to diagnose aortic stenosis, but the most common way is with a simple test we call a transthoracic echocardiogram. That test itself is where the patient comes in and we use sonar or an ultrasound wave to look at the heart and to see if the valve opens and closes well and how restricted it is. When a patient has symptomatic aortic stenosis, we at Capital Health System and really all over the country work as a team. We call it a heart team approach. One of the blessings about aortic stenosis is it's really a functional problem that can be fixed and in many cases cured. Now, there are a lot of ways to fix an aortic valve problem. One of the ways is with open heart surgery, or what we call SAVR, surgical aortic valve replacement. And that can be done either with a typical incision in the chest, or it can be done these days through a minimally invasive procedure that actually doesn't require incisions at all. It can be done through a robotic attempt, just like you might get for a gallbladder operation. Another way to fix it is something I'd like to spend time on, which is very popular these days called TAVR, or transcatheter aortic valve replacement. Transcatheter aortic valve replacement has been around for about 15 years and has really exploded over time. It was initially designed as a less invasive way to fix aortic valve stenosis in people who could not get surgery. At this point, it has exploded to include all risk groups, and now most people above the age of 65 are evaluated for this minimally invasive approach. Our program at Capital Health has been up and running since February of 2023, and by the end of this year, we will have done our 100th case, something we're very proud of at Capital Health System. Now, the way we fix these valves is fairly ingenious. There is actually a stent, which you see depicted here, and this stent itself is made of a cobalt chromium frame, and inside of it is a brand new heart valve. Once the stent is in place, the valve will function like a normal valve, and this stent valve has what we call a skirt on it, depicted at the bottom, which helps attach it to the patient's anatomy and prevent it from leaking. The way the valve is designed is depicted here. What we do is we have a valve that we put inside the old diseased valve, and this new valve is designed to not impinge upon the heart arteries and to stay very stable. The whole idea is once it's in position, we blow a balloon up to implant the valve, and then when we let the balloon down, the valve stays in position and functions as a normal valve. To get to where we need to go, multiple devices have been made. This is just a depiction of what we use to do the procedure. We have a very small tube that we put in through the skin in the femoral artery, which is down in the groin area, and we don't use incisions on about 95% of patients. This can go in through a small, we call it arteriotomy, and at the end, we either hold pressure or we have two little stitches we put in. Through that tube, the delivery system is able to be advanced and the valve can be put into position. The system itself is remarkable. As you can see depicted on the left, and I'll show you with my pointer, the system itself comes up from your leg, around and down to the heart, and it's designed so it can be flexible and maneuvered into any anatomy. It comes with a small dial on it right here, and what we're able to do is turn that dial, and it can actually flex the delivery system to point in the direction we need it to point to deliver the valve in the appropriate position. And here you see a case example where the tube comes up from the leg, comes around, and we're able to flex the tube and put the valve into appropriate position. On top of that, we really protect patients during these procedures. Through a wrist artery on the right-hand side, we have little filters that we're able to deploy in the right arm artery and the left neck artery to prevent somebody from having a stroke during the procedure. You can see at the top left these little filters that we're able to put into position, and this diagram down here shows you that when the device is in position, it protects the neck artery on the right and on the left, and it allows us to go around and put the new valve into position with minimal risk. Here's a typical series of events of how we do these transcatheter valve procedures. What we first do is get everything into position and put a little wire across the valve. If we need to, we open up a balloon, it's called a valvuloplasty, just to give us enough room to put the new valve in. We then go ahead and advance our new stent valve around the aortic arch and into position across the old valve. We then deploy the new valve, and in the end, we just leave the new valve behind functioning. This procedure takes about 45 minutes to an hour and can be done with very low complication rates. Here's a visual example of how precise we can do this. On the far left, you can see the dot, which shows us the middle of the valve and tells us where to land it. We take a picture to show us exactly where the valve should go. We blow the balloon up, leaving the valve in position. And you can see right here, the valve's in beautiful position, halfway above, halfway below. And actually, this is the left-sided heart artery. This is the right-sided heart artery that has normal blood flow. Now, when we look at a patient who has aortic stenosis, again, we really emphasize a team approach. We're blessed at Capital Health to have a wonderful cardiac surgical division, and there are some people who will do better with surgery. A lot of patients, though, do prefer the minimally invasive TAVR approach. It's done without general anesthesia, normally without incisions, and most patients with TAVR are in the hospital 24 hours and then they go home. The procedure itself has a very low complication rate, only about 3 to 7%. And really, in all patient subgroups, the data support its use. You can see on the right-hand side that when you compare surgery to the TAVR procedure, going out to 5 years, there's really no difference in how patients do. So this is why TAVR has really exploded across the world and has become, in many ways, the treatment of choice for this valve problem. Many people prefer it, and patient preference is always taken into account. Here you can see a graphic representation of how the transcatheter valve replacement procedure has exploded. If you just look at the far right-hand side and you look at people over the age of 80, which are these last two bars, you can see that 99% of people over the age of 80 are getting a stent valve, and less than 1% are getting surgery. So TAVR has really exploded and taken over quite the bit of the treatment strategy for this particular valve problem. Here's another look at the general volumes for transcatheter valve implant. You can see that in 2012, worldwide, there were about 32 transcatheter aortic valves placed. Now in 2025, the prediction is almost 300,000. So there's been a massive growth in this procedure, and it's really had a terrific impact on patients' quality of life and longevity. Now, the second disease process I'd like to go through is called mitral insufficiency or mitral regurgitation. And as we talked about earlier, the mitral valve separates the left ventricle, which is the pumping chamber, from the left atrium, which collects blood from the lungs. The mitral valve itself has two pieces to it, and it's supposed to stop blood from going backwards. Here you can see a graphic representation. Here's your mitral valve right across by ultrasound. And this little wisp of blood flow is going in the wrong direction. So the pumping chamber is down where my arrow is, the left atrium's at the top, and you can see a little wisp of leakiness. We would call that mild. On the middle slide, you can see a little bit more. We call that moderate. And on the far side, you can really see where there's severe mitral regurgitation. So this is what it looks like when we see it under echocardiography. It is very important to know that separate from the aortic valve, which had 2 or 3 leaflets, the mitral valve has multiple different components, and a problem with any or all of them can cause leakiness. The mitral valve itself is made of 2 pieces of tissue that are attached to thin filaments called chordae that then attach to muscular structures that are in the left ventricle called the papillary muscles. If you tear one of the chordae or many chordae, the valve can be leaky. If you have dysfunction of one of the muscles, the papillary muscles, you can end up having leakiness of the mitral valve. Or if you have a primary problem of your mitral valve, like mitral valve prolapse or an infection, all of those things can cause leakiness. So as opposed to the aortic valve, the mitral valve is very complex and requires the doctor and the patient to really investigate what the problem is to decide on the most appropriate treatment. Now, what can cause leakiness of the mitral valve? Well, a leaflet problem would be something like mitral valve prolapse, where there's extra tissue in the mitral valve and it just becomes leaky over time. Again, you can get it from an inflammatory process like rheumatic fever. Unfortunately, you can get a leaky heart valve if something eats a hole through it, something called endocarditis. I mentioned that if any of those little cords are torn, that can cause leakiness. It can happen all of a sudden, like in somebody who has a motor vehicle accident. It can happen from an infection or just because of degeneration. And again, you can get a mitral valve problem that is leaky because of lack of blood flow to a heart artery, or even just because the heart muscle has gotten weak. So there's many, many reasons for a valve to be leaky, and the doctor needs to be attuned to this when they're trying to make the diagnosis. We summarize leakiness of the mitral valve into basically two categories. One we call functional mitral regurgitation, and that is when you have a leaky valve because the pumping chamber of the heart is weak and everything has gotten bigger. And because of that, the normal valve has now been stretched and becomes leaky. That's called functional mitral regurgitation. We also have degenerative mitral regurgitation, which is when any of those other problems I mentioned occur. So when the valve degenerates, when something tears, when there's an infection. So degenerative is the majority of the time. Functional is from a weak heart that's gotten bigger. What are the symptoms people get with a mitral valve that is leaky? Well, it's very similar to if the valve is restricted. They get short of breath. They can wake up in the middle of the night not being able to breathe. They can just feel fatigue. They can get leg swelling. God forbid, they can get a stroke or a blood clot from fibrillation, or they can even get bleeding from their lungs, something we call hemoptysis. We know that when somebody has a leaky heart valve, the heart is working very, very hard. If you look to the right of this slide set, what we know as doctors is that when you have worsening leakiness of the valve, the stress on the heart goes way up. When that happens, despite the person's best intent to stay active and to try and be healthy, what will happen is that there will be muscle damage and muscle loss, further weakening of the heart because the heart's working so hard. The heart will get bigger and bigger and the leakiness gets worse. And this vicious cycle will just occur every time the heart beats over months and years. We know that if somebody has severe leakiness of a heart valve, that if it gets worse like this and the heart gets weak, there is up to a 60% risk of death in 1 year. So diagnosing the problem, especially when somebody gets symptomatic, is important early to stop this system of things that happen that cause the patient to have a bad outcome. Again, we know that when you have a leaky heart valve, bad things can happen. So when your heart valve is severely leaky, your risk of being hospitalized goes markedly up over 7 years. And we also know that if you have a leaky heart valve that's severe, that your chance of death goes up as well. So for patients with leaky heart valves, we always require people to come in on a regular basis to be monitored to ensure that the heart muscle remains strong and it's safe to treat people conservatively. The strongest predictor of outcome for people with a leaky mitral valve is how strong their heart is. And this is one of the most important take-home messages for everybody on this lecture, which is, as opposed to many other things in cardiology, if you have a leaky mitral valve and it's severe, we want to fix it before the heart muscle starts to get weak. We know as doctors that if the ejection fraction, which is a gauge of how strong your heart is less than 60%, that portends a poor prognosis. So we really want to get to people before the heart muscle starts to get weak, before that vicious cycle starts, because if the heart muscle strength gets below 30%, the prognosis of people, even with being fixed, is incredibly poor, and we can normally only offer them medical therapy. Here is an example of how we diagnose mitral regurgitation. Again, we use echocardiography. You can see here's moderate leakiness of the valve, where you see this jet coming backwards. Here's the mitral valve. This would be the left ventricle and the left atrium. And here you see a much more severe example where there's much more blood flow at higher velocity going into the back chamber. When we look at mitral regurgitation on ultrasound, we are looking for multiple different things. We're looking to see if there's a valve leaflet problem. Is it mitral valve prolapse? Is it a torn cord? Has the heart muscle gotten weak? It's very important that the doctor sees all the different nuances of the valve and does a thorough evaluation, because only then can you decide on the most appropriate treatment. Here is a great example that I wanted to show you that sometimes you may think the mitral valve is the problem and it's really something else. So if you look at the far left side, here you see a patient who has an ultrasound done because they're short of breath. This is the left ventricle. This is the left atrium. And you can see where my cursor is, severe leakiness of the valve, that bluish green jet that's coming through. And you can see it here as well. So this patient, for all intensive purposes, looks like somebody with a severely leaky heart valve that we might need to fix. What ended up happening with this patient was they had a heart artery blockage, and they got a heart artery stent. And 3 days later, after they got the heart stent, the echo was repeated. And now you see almost no leakiness going to the back chamber. See almost nothing coming through and almost nothing coming through. So in this case, this patient had severe leakiness of the valve because a heart blockage was causing dysfunction of one of those papillary muscles. So what you see is not always the primary problem, and really shows you how important it is to have a full and thorough evaluation by a cardiology expert. Now, when and if the mitral valve needs to be fixed, it is a very different world than with the aortic valve. Surgery is really the mainstay of therapy. When you have a damaged mitral valve, what can happen is that the doctor can go in and put a ring in. This is called an annuloplasty ring, where the doctor literally puts a ring around the valve and tightens everything up. So now a valve that was leaky because it was stretched apart, all of a sudden works beautifully. There is also a way to surgically repair a valve. So in these cases, you don't have to replace the valve. You can literally put stitches in the old valve and have it function normally. These surgeries can sometimes be done through a sternotomy, but in many cases, they can be done through what's called a port or a keyhole surgery with very quick recoveries and low single-digit complication rates. So surgery is a very important part of mitral valve treatment and really the mainstay. For those patients who are not surgical candidates, we also have a minimally invasive option. and that is a procedure called a mitral clip. What a mitral clip is, and you see the device documented at the bottom here, is a little device that we're able to put into position between the two leaky leaflets of the mitral valve and clip the leaflets together to stop them from leaking. The procedure itself is really a pretty exciting procedure. It's done under general anesthesia, but without any incisions, and we use it as a team approach with both a surgeon and an interventional cardiologist in place. We put a tube up from your vein into the right atrium, and then we're able to go across to the left side of the heart, and we have a little tube that directs us downward. We start right above the mitral valve, and what we're able to do is put the clip down through the valve, pull it back up, grasp part of the leaflets, and leave that little clip in place to stop the leakiness. Here is a picture at the bottom of how this looks when it's done. So the two leaflets of the mitral valve are this one, and in the middle here is the clip that was used to pull things together. What it does is it creates a tissue bridge, and you can see kind of how it looks here, to try and stop the leakiness and minimize it. And it has been shown to restrain the heart from dilating and help people do better. Here is a typical case example. This was an 87-year-old patient who had had multiple hospitalizations for heart failure. Her heart was still strong, but she really was not a good candidate for surgery. She had almost an 8% risk of death if they tried to repair her valve and a 10% risk of death with replacing it, so she was referred for a less invasive procedure. Here's an example on the left of how leaky her valve was. Again, you can see here's the left ventricle, the pumping chamber of the heart. At the top is the left atrium. Here's the mitral valve. And you can see this big jet of leakiness that's coming across the valve. We were able to put a clip in place, and after we were done, no leakiness. So here's the clip, and it actually took care of all the leakiness and only left this small wisp of blood flow, and she felt better really immediately after the procedure. Now, these procedures work. They do very, very well over time. You can see here for the MitraClip procedures that people who get hospitalized with heart failure, if you just took medications, you had a pretty high risk of being rehospitalized. But if you went ahead and had the MitraClip, that risk was cut in half. So really a great procedure to reduce hospitalizations for heart failure. And as can be shown here, over 2 years, people who had the MitraClip did better in terms of survival than if they just took medical therapy alone. In conclusion, heart valves are essential to the normal function of our circulatory system. They can have sudden or chronic problems that cause symptoms and can affect a patient's longevity. Recognizing the signs and symptoms of valve disease are really important and can help your physician make an early diagnosis and get you a prompt referral to a heart valve specialist. The Capital Health Cardiology team, as well as the cardiac surgeons, are really at the forefront of this and can be helpful if problems arise that need surgical or minimally invasive therapy. And hopefully that was a good outline of heart valve disease and highlighting a few different heart valve problems, and I'm happy to take any questions.
Dr. Drucker, this is Diane, and that was so very informative. I do have a couple of questions that were submitted during your presentation. The first one is, how many Capital Health surgeons are performing the TAVR procedure, and what is the success rate?
So we have 2 Capital Health surgeons that work with us in doing the transcatheter valve implant, and the success rate is very high. At Capital Health System, our success rate is 95%, so a very high success rate with very few people needing surgery.
Excellent. Another question was, why would a patient choose surgery rather than the robotic procedure?
So that's a very complex question. And again, I think it's really important. When it comes to choosing surgery versus a minimally invasive approach, most patients, and I would be one of them, always want to recover quicker, have less pain, a faster recovery, get back to work as fast as you can. And so most people will pick the less invasive procedure. What's important to know, though, is that these less invasive procedures, just like any procedure, can over time have problems. So, for instance, a heart valve, a transcatheter aortic valve procedure, we know that people do very well with it, but over 10 years or 15 years, valves can degenerate. If you're 80 years old or 75 years old, usually having a valve procedure that's minimally invasive is the right thing to do. But if you're 60 years old and you have a choice between surgery or a minimally invasive procedure, oftentimes the surgery is the better answer because you're young and healthy. The surgery will replace the valve completely. And then in 10 to 15 years, if the surgical valve fails, you can always get the stent valve because you'll only be in your 70s. So, what we do a lot of times for patients is to give them the broader picture before they make a decision. There are also anatomical features or clinical features of a patient that make surgery a better option. So there are a number of reasons why surgery might be chosen above the minimally invasive procedure. And that's why every patient who gets a minimally invasive procedure referral is also seen by one of our heart surgeons. So we can all talk and truly have a team approach with the patient.
Okay, the next question is, what is a heart murmur and is it valve related?
So, a heart murmur is when a physician or practitioner puts a stethoscope to your chest and they can hear a sound of blood going past one of the heart valves from one chamber to another. Without sounding terrible, it sounds like a swooshing sound. Okay. And every patient can have different intensities. It can be loud, it can be soft, but you can hear it with your stethoscope. Sometimes it will indicate a heart valve problem, but sometimes it doesn't. For instance, somebody who has anemia will often have a heart murmur. And that's not because they have a heart valve problem. It's just that the heart is beating faster and harder, so you can hear the blood going past the valves. When the anemia is taken care of, the murmur will diminish or go away. So a heart murmur can indicate a heart problem, a heart valve problem, but doesn't always indicate one.
Then the second part of that question is, why are they being told to take an antibiotic before a dentist appointment?
So that has been minimized over the past 5 to 8 years. So whoever asked the question is absolutely right. Many years ago, we became very attentive to this rare problem that could occur before you go to the dentist, which was that if you didn't take an antibiotic, if you had a heart valve problem, you might get bacteria from your gums or your teeth into your bloodstream and develop an infection on a heart valve called endocarditis. That is a very difficult diagnosis. It requires treatment with antibiotics for 4 to 8 weeks, and sometimes it can cause some of the heart valve problems that we've talked about tonight. For many, many decades, we had broad indications to give people antibiotics before dental procedures. Things like mitral valve prolapse, for instance. We would give everybody antibiotics. What we found over time, and there are some new recommendations that your practitioners can review, is that antibiotics before dental procedures are only needed for a very, very select and high risk group of patients. For instance, somebody who has a prosthetic heart valve, so somebody who's had a surgical or a transcatheter valve put in, those people have to go ahead and take antibiotics before they go to the dentist, because if something gets into the bloodstream, it can seed onto the metal portions of the valve and cause an infection. But most other risk groups have been minimized, so it's really the exception more than the rule that people need antibiotics before dental procedures in 2024.
Okay, then I'm going to ask one related question that came in that says, if your heart murmur gets louder and you have aortic valve stenosis, what does that increase indicate?
So, frustratingly, sometimes it means nothing. So, again, let's take the anemia example. If somebody has mild or moderate aortic stenosis and they come into the office and they go, I'm fatigued, I don't feel great, and you listen to their heart and the murmur is louder, that could be a lot of different things. It certainly could be that the valve has gotten worse, but it also could be that the person is anemic. It could be that they're dehydrated. It could be that they have an infection. Anything that causes the heart to beat faster will make the murmur sound worse. So you have to take the patient's whole clinical situation into account. Louder does not always mean worse.
Okay, we have a very engaged audience tonight. The next question is, what is the difference between shortness of breath from asthma and from aortic valve stenosis?
So, a very difficult thing to differentiate. Normally, people with asthma will have some component of wheezing. So, when they take a deep breath, they try and breathe out, there's restriction to airflow movement, and they have a very hard time not just breathing in, but also breathing out. Usually, people with aortic stenosis, it's more just they're short of breath and fatigue with whatever they do. Unfortunately, it can be very difficult for any patient to tell the difference between pulmonary shortness of breath and cardiac shortness of breath. Clinicians have a problem differentiating it as well. So, what we advise patients who both have an aortic valve problem and asthma or emphysema from smoking is, if your shortness of breath is getting worse, it's always good to contact a practitioner. Normally, if you have asthma, there'll be significant wheezing that the doctor can hear, and there won't be a heart murmur. If it's an aortic valve problem, there usually isn't wheezing, it's more crackles. So we hear fluid in the lungs, and we can hear the valve problem with the stethoscope. But this is very difficult to diagnose by yourself, and we always encourage an evaluation by a practitioner.
Can you describe the pre-procedure workup for a TAVR TAVR?
Of course. So the pre-procedure workup for a TAVR is a number of things. The first, and I believe I mentioned, is the team evaluation. And that is that every patient is evaluated by a structural or interventional cardiologist, such as myself, and separately by a heart surgeon. That is a national mandate to make sure everybody agrees that the transcatheter valve procedure is the right thing to do. The second thing is a patient needs to be seen by a dentist to make sure there's no infection in their mouth, because you cannot get any new heart valve if you have an active dental infection. The third is that a patient needs a CAT scan. So they have to get a CAT scan that we order specially that looks from your collarbone down to your groin area. It lets us make sure we can get to the heart to put the valve in, and it also helps us choose the appropriate size of the new valve. So you need an evaluation by a surgeon, evaluation by an interventional cardiologist, a dental clearance, a CAT scan, and then lastly, you need what's called a heart catheterization, which is where a doctor like me puts a little tube in the wrist artery, goes down and take pictures of the heart circulation are the heart arteries, because 50% of people who have an aortic valve stenosis also have a heart blockage they don't know about. That is the general workup for TAVR, and then we put all of our thoughts together to come up with a plan.
Okay. The next question is there any correlation between having heart valve issues and vein issues in one or both legs?
So that's a complicated question. In general, vein issues are separate from heart valve issues. That being said, there are heart conditions that can cause engorgement of your veins and cause, let's say, vein problems to become more symptomatic. So just I'll take the mitral insufficiency or mitral regurgitation. In the worst case scenario, that goes on for long periods of time. The heart becomes weak and everything backs up. So everything backs up from the left side of the heart through the lungs into the right side of the heart, and all your veins become engorged. That usually we see in patients who are very end stage. They'll get terrible swelling in their legs, engorgement of their veins, their stomachs will get bigger because there's lots of fluid there. So is it possible that somebody with symptomatic vein problems has a heart valve problem? Yes, but in general, veins and heart valves are separate.
Okay, what looks like our last question is, my family has a history of heart disease with both parents having had valve replacements. Being in my early 60s, I'm guessing I will have to have a valve replacement at some point. How can I be proactive in monitoring my valves? Should I visit a cardiologist on a regular basis?
So a great question. So when you hear about first degree relatives having valve problems, what you worry about is that congenital problem I mentioned called a bicuspid aortic valve. And in or even a mitral valve problem where you have mitral valve prolapse. Some of these heart valve problems can have a small inherited component to it. Normally, the easiest thing to do is to go see your medical doctor. And if they're uncomfortable, then yes, go see a cardiologist. And you would just need a baseline ultrasound test of the heart. That should be able to tell that echo whether or not you have any inherited valve problems that mandate being followed. If your ultrasound test of the heart is totally normal, then you may very well not have inherited the predisposition through your parents to a heart valve issue. But it certainly is something to mention to your practitioner, and a baseline ultrasound test of the heart would be a reasonable step to take just to give you some confidence that your heart doesn't have any problems at the moment.
Okay. Is it possible to go into surgery for a TAVR procedure and end up having open heart surgery? And why does that happen?
So, a great question. So, the answer is yes. Every patient that goes for a minimally invasive procedure, whether it's a gallbladder or a heart procedure, anything like that, we always consent them for open surgery. And the reason we do that is that 99 times out of 100, the procedures go as planned, but sometimes something might happen. For instance, sometimes if we're doing a transcatheter valve procedure, we put the new valve in and it shifts position. So it could move all of a sudden due to technical factors. It's very, very rare that it happens. But when it does happen, most of the time we can fix it with balloons and stents, but rarely we need a surgeon to go in and either reposition or take that valve out and fix things surgically. Okay. There's a number of other reasons why a surgeon might be necessary. It could be because of an injury to a blood vessel, something along those lines. So, again, it is certainly possible for any minimally invasive procedure on any tissue that surgery happens. It's relatively rare, but it's always a possibility.
Okay, and then I think our last question that we'll wrap up with is, oh, I'm sorry, can malnourishment cause a mitral valve regurgitation?
Wow, that's a very insightful question. So the answer is sometimes. So when you're malnourished, there's a lot of things that can cause a leaky mitral valve. The most common thing would be that you can actually develop weak heart muscle from malnutrition. And when that happens, that diagram I showed you where the heart gets weaker, it starts to get bigger, it pulls the two leaflets of the mitral valve apart. That can happen, and you can develop severe leakiness of the heart valve just based on that. So, is it possible? Yes. It's really not the most common thing we see, but certainly poor nutritional status can be a factor.
Okay, well, I would like to thank you, all of the participants on behalf of Capital Health and Dr. Drucker for a very informative presentation this evening. This was absolutely terrific. If folks would like to get in touch with your office, do you have an area that they should contact?
Yeah, so Capital Health Cardiology Specialists, we're a team that works together. We have a central number you can see on the Capital Health website. I see patients in four different offices, three in New Jersey and one in Pennsylvania, and we're always happy to be of service.
So again, I would like to thank everyone. Wish you a very pleasant and safe evening. And I will hang on a few minutes if anyone would like to reach out to me. But thank you again.
Thank you. Good night.
Good night.